Good evening, and a very warm welcome to all of you joining the webinar this evening. My name is Jerard Ross, and I'm one of the medical legal advisors here at the MDU, and I'm going to give you a brief presentation on complaints in secondary care, and ideally take some questions from you at the end, because I'm lucky to be joined tonight by two of our very senior colleagues within the department. We've got Dr. Gaynor Whiter and Dr. Nandasoma, who Ed is the head of advisory services, and these are the people that I go to for advice regularly. So I would expect them to give us really good answers to your questions. Talking about questions, do your best to submit your questions as early as possible using the question box. If you keep your questions short and concise, it makes it much more straightforward for us to answer them. We've got 1,400, 1,500 registrants for this evening. Not everybody will turn up, but still it's quite a large volume of questions. So there's just no way that we're going to be able to get to all of them. If you are a member of the MDU, you've got a pressing question, we're here to help you, and you can write into us through the normal channels. There will be certificates of attendance available. You can keep those for your appraisal, and they're going to be available shortly after the webinar, but you do need to give us some feedback. Be gentle. You need to give us some feedback. And what I'm specifically not going to do tonight is go into the nitty-gritty of the complaint processes, because as generally employed doctors in secondary care, I know some of you will be private or have mixed practices, but as employed doctors in secondary care, the details are going to be managed by your employers generally, and they vary across the different nations of the UK. This session is being recorded and is going to be available to watch on demand through our website and on the YouTube channel as well, should you need help in dropping off at night for getting to sleep. So what are we going to talk about? We're talking about complaints, and I'm going to start off by talking about something that's not specifically about complaints. I'm going to talk about the GMC. This is an MPTS hearing room. It's the functionally separate part of the GMC that holds doctors' fitness to practice hearings. Doctors' fitness to practice hearings can be found, or doctors' fitness to practice can be found impaired on a number of different grounds, including misconduct, deficient professional performance, a conviction or caution, adverse physical or mental health, and not being able to speak English well. There are some things that are almost always going to result in a doctor being in a hearing room like this. For instance, a criminal conviction resulting in a custodial sentence, repeated dishonesty, exploitation of a therapeutic relationship for personal gain, and just refusing to engage with a GMC process. Those are things which are likely to end you up in a room like this. But you'll notice in that list I didn't say one clinical error. Single clinical errors generally don't result in doctors ending up in MPTS hearing rooms. But the dividing line between a problem that is going to be easily managed and one that the GMC will take forward can be quite hard to identify earlier on. And my sort of raison d'etre, if you will, is to try and keep our members out of rooms like this, considering the specific risks to them and how we can manage those risks. Because as we all know as clinicians, things can go wrong. I often like to start or to share this quote, which is quite an instructive one. As clinicians, we all have clinical situations that get out of hand. We all have outcomes from interventions or treatments that are not what we expect, even in this day and age. And when something goes wrong as a doctor, things can rapidly spin out of control. If any of you have been to one of our previous webinars, you will have seen this slide. And No apologies for that. It's an important slide. We share this for a reason, because when something goes wrong and you end up with an NHS complaint, there are a number of other things that can happen. I used to spend a lot of time worrying about civil claims. There's a risk around criminal investigations. That's something that's much more prevalent within England than other parts of the UK. There's a risk of disciplinary investigations. There's a risk of GMC investigations, and those are really the ones that have the biggest impact on doctors' ability to do their job and to earn a living. So what we tend to think about, what I like to think about when we come to complaints or problems that have arisen in the clinical practices, how would the GMC look at this? Because there are a lot of complaints every year. These are the English figures. So you've got 230,000 complaints every year. There's only 350,000 doctors in the UK registered this year. So that's a lot of complaints that can come in, and the numbers go up every year. And if we add in Scotland, Wales, and Northern Ireland on top of this, we're up northwards of 370,000 at a rough guess. So if we think about that figure there, first of all, and also look at the fact that a quarter of them are upheld, that's a lot of you in this room who might be involved in a complaint this year, or may have been involved in a complaint in the last few years. But holding that number in your head and moving on to the next slide, we can see that in reality, although there may be, let's say, 270,000 complaints through the UK to the NHS, a much smaller number end up with the GMC. Okay, so you can see that over the years from 2014 to 2023, we're averaging between 7,000 and 9,000 every year. Okay, and then if we go further and look at the actual complaints to the GMC, or referrals to the GMC, should I say, which end up with sanctions being applied, it's even smaller again. So about 2% of doctors will end up, after referral, end up with an NPTS hearing. So it really is a small amount. And why is that? Well, some referrals or some issues are about things that really don't speak to fitness to practice and are closed early. As I said, there are always some that are going to end up in a hearing. The criminal conviction is an example. But between these two poles, there are cases which are remediable, cases in which you as a doctor have got agency, can take steps to protect your position, just in case the issue gets to the GMC. And that it only takes one upset or annoyed relative for a case to end up at least being reviewed by the GMC. But of course, you saw the figures there. There's a vast disparity in numbers between the cases that are complained about and the things that go to the GMC. And within these cases at the GMC, a significant number will not be specifically related to the clinical care of a patient. They may be related to other issues like a doctor's behaviour in their private life, or a criminal conviction, or something else. But the problem is that when we look at complaints that doctors face, we know that it's hugely distressing for them. About a quarter of hospital doctors, that's consultants and trainees, talk about being significantly impacted by complaints against them. That was a survey that we did of our own members. So significant impacts: not sleeping, not eating, time off work, loss of confidence in the clinical arena. So complaints might impact patients, but they also impact those being complained about, you tonight. So let's quickly look at a complaint. This is a made-up complaint. I've drawn the type of complaint. It's the sort of thing that we will see quite frequently. The actual detail I've just taken from the NAP data on anaesthesia. But this is somebody admitted under orthopaedic surgery, given teicoplanin prophylaxis, ASA grade 2, on the large side, without any known allergies, developed hypertension, bronchospasm, and then a pulseless electrical activity, cardiac arrest with a prolonged resuscitation. Then had bilateral posterior cerebral infarct and a resultant cortical blindness, which I have seen in a similar situation. And the patient was dependent on carers. The trust got a complaint, and that complaint was copied to the GMC, which we see happening from time to time. There are other people that people will send complaints to. I've seen them go to Jeremy Hunt. I did pronounce that right. Jeremy Hunt has certainly got them when he was Health Secretary, and we see them being fired off to all places. But it's not unusual for them to go to the GMC. It's not unusual to go to a coroner, although clearly not for this patient. But this is an issue that can be considered by lots of people, lots of parties. So a trust or a health board if you're in Scotland or Wales, the Health and Social Care Trust in Northern Ireland. And if it goes beyond that, if the family or the patient are not happy with how that organisation has managed the complaint, then the Ombudsman could end up reviewing that response as well. And that happened to be in my last clinical complaint before leaving clinical practice. I had a complaint arising from interaction with a patient. I think I may have expressed that their significant BMI might have contributed to the symptoms they were having in a gentle way. I certainly didn't do in any other way. The complaint went to the health board. I was working in Scotland. I had to answer it, and then it went on to the Ombudsman, who wanted to see in what way I had remediated from that. So that was actually really stressful because I had discussed it in my appraisal, had all the things that I'm going to talk to you tonight about, but it was a very distressing thing, and I ended up speaking to some of my colleagues in the MDU about it. If you are in private practice, of course, you don't have that Ombudsman layer. So the patient might complain to you as the provider, they might complain to the hospital in which you work. But after that, they don't have an Ombudsman in general. There's a thing called ISCAS, which does look at secondary care, private practice as an Ombudsman would, but they're voluntary and they don't apply to all providers. So it's likely that the only thing after a local complaint, if you're in private practice, is to go to the GMC, and we see that quite commonly. What else could the trust do? Well, the trust might have to, or the health board, so I should say, might have to have an SI or a significant adverse event review if you're not in England. The MHRA might have to get a report because this may well be related to the drugs that the patient got. There's going to be a GMC notification in this case, but they may not open an investigation. They don't tend to. Let's get this into context. If the GMC get a complaint raised to them from an employer, say your responsible officer says, I'm really worried about Dr. X and what's happening with their clinical practice, there's a very high chance the GMC is going to open an investigation into that doctor, not the RO, but the doctor about whom the RO was speaking. If a family member raises a complaint or a concern about one clinical incident, particularly about a clinical incident involving a doctor, then the chances of them actually going and opening a formal investigation into that are on the lower end. They're certainly not as high as if another doctor does it. There could also be, in this case, a claim of negligence. The claim would be brought against the trust, against, in England, the clinical negligence scheme for trusts who would defend that. In private practice, it would be brought against you, and you would come to us for assistance, assuming you were a member. Those are all things that can happen, but the one that is probably the most impactful, as I've said, is the GMC. But what we want to make sure is that you have given the GMC every opportunity to close the case. So moving on to that first slide again. So what we've got here is we've got a complaints process started. We may have a GMC investigation, and we may have a civil claim. I suppose that if there were lots of similar cases of similar tenor about a doctor's performance, then that's going to get you on the dashboard of your RO, and that could be added into their concerns, and they might in that situation consider a disciplinary investigation. Clearly, if the patient had died, there would be a coroner's investigation in England, Wales, or Northern Ireland, an FAI in Scotland. So, as you know, you have obligations as practitioners, and doctors have a GMC obligation to respond to complaints. This is a picture of the new good medical practice, and on the next slide I've got a QR code so you can download that and have a read of it if you haven't done so yet. So taking things slightly to the side, it's more of an evolution than a revolution in terms of how the GMC are approaching things, but it's worth having a read through, and it's something I think that we'll end up having a separate webinar about at some point later in the year. So that's the QR code. Please feel free to get a snap of that if you haven't read it already. So how do you respond to these complaints? Well, the first thing to say is that in general, and it isn't in general, they don't complain maliciously. Patients may have views on the aspects of the care that they've had, but they're likely to genuinely believe what they say happened, even if you disagree. In general, it's not a personal matter, and what they're talking about is their experience, and the important thing is to recognize that experience and think about whether it could have been handled differently, whether it could have been handled better. So don't panic, don't go back and alter the record, which we've seen happen, unfortunately. Don't disparage somebody else in communication, because remember, all that communication in the trust or health board or local health board, that's all disclosable to the complainant as well. So breathe, be professional, realize it's not personal, and think about what steps you need to take in dealing with that. You have to own it, if you will. You have to be seen to cooperate, and you have to do your best to explain it. Many of you will work in highly technical specialities, like me, explaining, from when I was a consultant, explaining the intricacies of an operation I had done to lay persons within a health board or a trust is quite difficult. And similarly, when I look at responses from psychiatrists who are very engaged in a quite a complex treatment paradigm for patients at times, or anaesthetists or obstetricians, they're so full of jargon that it can be quite hard to follow. So you have to explain it in a way that makes it clear to lay persons, that's the patient, their family, their solicitors perhaps, what has actually occurred. And it's appropriate to apologise if it's appropriate to do so. I know that people get concerned about the idea of an apology, and I understand why. If somebody has a complication arising from their surgery, and this is a complication that you discussed was a potential outcome from the intervention, and they have it, you may well apologise to them for how things have turned out. That seems reasonable. If you've warned them in advance that that was something that could happen, it's a recognised complication, then I don't think you need to do much more than explain it in a rational way why it happened. Go back and explain this was something that we discussed about. I think that's probably enough. But if you actually think, do you know what, we got this wrong, we could have done this differently, my junior might have interacted in a different way, they may have passed on some information to me that was relevant, that I would have expected to have, I could have stopped and listened to what was being said and reacted to it properly. That, I think, is when it's probably appropriate to make the apology very clear and very specific. But again, only if it's appropriate. If you don't think you've done anything wrong, and the general consensus of other people, your peers who understand what you do, they don't feel there's anything wrong, then you don't need to apologise if everything's been done correctly. You need to be empathetic, but apology is only when it's appropriate. Sometimes it can be hard to be sure, and that's the circumstance in which we'd hope you'd run it past us to get some advice. So in terms of that, if you do feel an apology is an appropriate thing to do, then saying, I'm sorry that X, not something we see quite frequently, sort of weak apology. I'm sorry if you feel Y. I'm sorry that if you feel upset by what's happened. Or I'm sorry that you felt it necessary to complain. Those are sort of weak apologies, and they're generally not very helpful. But again, if you think you could have done something better, then you can say so empathetically and clearly. Your employer should be including your commentary for the patient. It might be edited. So for clarity, it might be edited for clarity, apologies. But it's important for that reason you go to your employers and you ask to see a copy of it before it goes to the patient to make sure that it's accurate. Because as a specialist, you will have perhaps more knowledge than the team who are putting together the response. Make sure you've responded to everything that you're able to respond to. Some things will have nothing to do with you. It might be to do with the anaesthetist or the nurses on the ward or another team to whom the patient was referred. Address your parts of it. The organisation will pull it together. Your job is to deal with your part. But make sure that you discuss it in your appraisal. Make sure that there's a case review and you discuss it in your departmental M&M, for instance, that you've talked about it with other people. And if there's any learning points that you have talked about them with your juniors and with your colleagues. That's really important. If you can evidence that, if you can have an entry in your appraisal for that year which says, and I talked about this complaint here and this is what myself and the appraiser discussed, then that means that if you are unlucky enough to be one of the doctors who has a complaint that goes elsewhere, the ombudsman like I had, the GMC, then you've got some evidence which demonstrates your attempt to remediate, which I'm going to come on to again. That sort of remediation is part of, that talking about the case is part of the personal reflection that we think is vital. The organisation itself also has to be seen to reflect. So the organisation has to think about if there are any systemic things in how the system has been organised which have impacted on the patient. And the organisation also has to think about the duties of candour, which I'll come on to very briefly in a minute. So these are all things that have to happen, and the first part of that for you is being reflective. This is the reflective practitioner. I make no apology for putting it up. I do put it up from time to time. There's a link there you can get. I know there's been concern about reflection, and it's really been in the sort of zeitgeist for a long time. A lot of it came from the Bawa-Garba case, and I still hear doctors telling me that they will not reflect for fear of it being used against them. Dr. Bawa-Garba was not a member of the MDU, and it's not for me to talk about that case in detail. There's a lot written about it in the medical press, and you can read about the case directly from their defence organisation. But the reality of it is the details of her personal reflections were not used against her in the criminal case. The reflections did come up in aspects of the case. But for the vast majority of doctors, reflections are an important positive thing to add into the mix of information that will be considered by the GMC, be considered by your employers. If there's a disciplinary issue, they want to see that you've thought about things. In general, the GMC doesn't ask doctors to provide their reflective notes to them, although we often suggest to doctors that they should. Because, as they say in this joint guidance, evidence of insight and remediation, that reflection, that CPD, that change to the PDP going forward, reduces the need for the GMC to take action. You're all experienced doctors. You don't need to tell me to tell you how to reflect. So I'm going to go past that quickly. You'll all also regularly be involved in significant event analysis. It takes different forms in different parts of the UK. And in fact, there's been a new process just introduced in England this year. It was piloted, I think, towards the end of last year. And I've got a link to some guidance about that on the next slide. But the point is, the organisation has to demonstrate that it too has learned from the events of the incident. You'll have seen some press coverage about the Ombudsman from the Parliamentary Health Service Ombudsman from I think about 10 days ago now, suggesting that organisations have not been great at learning from events, at least in the view of the PHSO. This is a link to the patient safety incident framework for you to have a look at if you're working in England. There are different frameworks, as I said, in different parts of the UK. We've talked a little bit about duties of candour. I've mentioned it earlier on. So there is this thing called the professional duty of candour, and that's something I've already mentioned to you. It's that this is the professional or ethical duty of candour. Okay, so it's the idea that you are obligated to put matters right if you can, to apologise if it's appropriate, to explain fully and promptly what has gone on, and to report the incident in line with your organisation's policy. And that's the new part that's been introduced in the new Good Medical Practice, which came out, I think, on the 20th of January. There are also legal bases for disclosing information, statutory duties of candour that vary depending on your jurisdiction. That's the statutory duty of candour. It's well established in England and Scotland. Wales introduced their statutory duty last year, and Northern Ireland are still in discussion about how and when they want to implement it. I'm not going to go into details about it. We've got plenty of learning on our website. I'm going to give you a link to the website at the end. But the bottom line is that both these duties result in doctors or organisations telling patients about things that have occurred. There may be other things you need to do as well, and in this case, it might be that an MHRA notification needs to be made. If it involves devices, you might have to tell somebody about that, MHRA again. There's some circumstances when something goes wrong that you may have to notify the healthcare regulators directly. So the CQC may need to be told about certain incidents, patient safety incidents, part of the duty of candour. And then if something goes wrong and you end up in a coroner's court or an FAI in Scotland and the coroner criticises you as a doctor, then that's a situation that you have to disclose directly to the GMC. It's not very common, but it does occur. So why are we talking about all these things? Why have I mentioned the GMC so many times? Okay, well, this is what happens when a complaint goes to the GMC, and I think you will see by these arrows coming off it that after the complaint is notified, there are a number of opportunities for the GMC to take the complaint off the ramp of progression toward an MPT hearing. There are lots of opportunities for you to provide information with assistance from us. And what the GMC is looking for is evidence of current impairment of fitness. They're looking for evidence of your current fitness to practice. So they're not looking at whether you were fit to practice at the time of the incident. They want to know, how are you now? Have you developed and changed since this incident that has been reported to them, since the series of incidents that's been reported to them? How have you developed since then? What and how can you evidence it? That is what is the key, really. That's what speaks to your fitness to practice. And this is a slide I've shown a few times. The study is a GMC study. I don't have more up-to-date information because they haven't done the study. But this is when the GMC looked back at their case 11 years ago now, and they took out all the straightforward ones where a doctor was going to be impaired, like the convictions or serious concerns about a doctor's health, and they analysed the other 147 cases. And they demonstrated a really striking difference between the groups. Of the doctors who they felt had shown insight, a small number were erased from the register. For the doctors who did not show insight, a much greater number were erased. Now, so insight and remediation are important in panel hearings, but they can also be really influential earlier on in the processes. If you're not clear what I mean by that remediation, it means that a doctor is likely to have had to have insight if they accept they perhaps should have behaved differently. They're showing empathy and understanding of the situation, have taken timely steps to remediate and apologise at an early stage in the process. So, and demonstrated timely development of insight during the investigation and hearing. So, all of these things to me suggest that these are things that are worth doing early on as a general approach to complaints and things that have gone wrong. One of the great difficulties, I think, is that as an employee, you are subject to the policies and the procedures of your employing organization. You have managers to whom you are responsible. You have a responsible officer who will have a dashboard of concerns that are brought to their attention regularly. And that responsible officer will be liaising on a weekly basis, certainly, with the GMC through the employment liaison officer. So you want to be able to lay down all of the information to your RO to reassure them that there aren't any particular problems. The NHS is also nearly a monopoly employer, frankly speaking, in the UK. Yes, there are some doctors who work solely in private practice, but in NHS practice, information is exchanged between ROs. So you have a bad run at one hospital, you want to move to a different hospital, there are questions left outstanding that have not been addressed. That information will be passed on to the next RO, and you don't have control over that information. You might get to see it if you ask, but you don't get to say how that information will be exchanged. I've already said that there are expectations placed upon you because you're a registered professional. You have to engage with complaints. We've said that. You have to be reflective, you have to be open and honest. Patients are not registered. They may not be reflective, they may not even be honest. But the important thing is to act professionally and to engage with things when they come up. I think the other thing I've added to the slide here is that you're almost certainly replaceable. One of the problems that we see, particularly I think with senior doctors, is they become so used to being the expert in the room. People defer to them, rightly so. But when they're challenged, they sometimes don't deal with challenge well. And I think that's one of the difficult things of being in a high pressure consultant role, that often we're not challenged by other people, and that when it does happen, it can be hard to deal with. But we're all ultimately replaceable, and I say that with my boss listening to what we're saying, so I'm conscious that I am too. This quote is one that, again, I have used before, and I'm sorry for repeating it, but I think it bears repeating. The savvy doctor recognises that, uncomfortable as it may be at time, over the course of their career, concerns are now likely to be expressed by many doctors' practices. Most of those issues are unlikely to be career-threatening unless they're handled in ways that compound the issues. And that's what we're trying to avoid. We're trying to avoid making it worse. Saying, I have to know more about this concern, so we can dismiss it or resolve the issues is behaving impeccably, so my colleague said. And it immediately enhances their credibility and position for ensuing discussion. So responding to the concerns about your practice, be that a complaint or a series of complaints, saying, yes, I absolutely understand why you have to look at that, is the best way of engaging with these things when they do come up, rather than saying, well, what about that? What about that person? Those other issues can be dealt with in time, but the important thing here is to focus on the patient and to do your best to address the issues with our help. That's what we're here for. So complaints are frequent, very frequent in fact. It's likely quite a lot of you here tonight have one already this year or are engaged one right now. They're very stressful and they're an important source of learning and can be quite impactful for doctors for a number of different reasons. It's important you engage with the complaint, that you communicate clearly and reflect and share that learning, and that you engage with the employer processes. I think it's also important that you get help because it is stressful. We are here to help you, and we would like to take the opportunity of doing our best to assist you when a problem comes in. We don't necessarily tell you what you want to hear, but we're often there as a sounding board, and we tell you things that we think it's important to air, and we'll try and do that in a sensitive way to support you, to look after you when things are not going well. So we would like you to involve us as well. This is a link to our e-learning, and there's lots of information on there about complaints, about different jurisdictions, about things around that, and I would urge you to look at that. You can get certificates associated with that as well. Put it into your CPD for the year. It will only be of use. So when the inevitable happens, and you're one of those 300,000 doctors or 280,000 doctors a year across the UK who get a complaint, when something happens, something appears to have gone wrong, I think you can follow the advice of Elvis and say, when things go wrong, don't go with them. And on that throwback to an ancient era, should we maybe see if we can take some questions? Gaynor and Ed, are you around? Hi Gaynor.
Hi, Ed, are you there too?
Hi Jerard. Yes, we are. A couple of things. Firstly, there's a few requests for the QR code to download good medical practice. I wonder whether we could scoot back to that.
That's fine. Let me do that now.
And we've got some really interesting questions here that I'll sort of bring up. Maybe an old chestnut, but it doesn't make it any easier, is what should a doctor do, or what rights does the doctor have when the patient makes a complaint which you think lacks truth?
Okay. One of the difficulties, of course, is that often you're seeing the patient. There may not be other people around as part of that conversation. Or it may be that you're seeing a patient and they have attended the clinic, for instance, with their next of kin, and both them and the next of kin are reporting a particular thing that you know is to the best of your knowledge inaccurate. I think in that circumstance, you need to refer to your notes, you need to refer to your normal practice, and you can respectfully disagree with how something has been put, and you can say that is not my recollection of occurring, that would not be my normal practice. I think that going in and saying, well, you're just lying, that's probably not going to help the situation settle down, but you can indicate that you disagree with the facts that are being asserted. And I think that's another important part of the actual response itself. You have to put down the facts of what occurred in your response. And those will then be seen by other parties. So if it were to go, for instance, to the Ombudsman or to the GMC, they'll see the complaint and the facts that they assert, and then they'll see what you have said, and they'll probably see the records as well. So there's a lot of backup for for doctors. I think that what I wouldn't want you to do is to fly off and to start be seen to be suggesting that somebody was lying, because often these things are so distressing for patients and doctors, but for patients particularly, that they have one consultation with one doctor, whereas you as a consultant may have 20 in a clinic. So they may have a very clear recollection of it, which may be distorted by illness or emotion. So I think that being professional and handling is probably the right way. Gaynor, would you add anything to that or disagree, please?
No, I think that's absolutely right. I think the first thing I think that doctors sometimes feel is that it's just incredibly unfair, and the patients have everything on their side and they have all the rights and doctors don't have any. And I think the first thing to do is to, as you said, Jerard, really breathe and just try and take a step back, because you know, you're doing something on a Tuesday afternoon and it might be your 17th person that you see, whereas for them, as Jerard said, it's their one opportunity. They may have been waiting for weeks or months to see you, so they may view it very differently. You might be a bit tired as well, or a bit cross because you know you're running late and you've got 17,000 patients to see. So sometimes you know, the patient will really believe what they say has happened. Your records are going to be incredibly important, so it is really important that you document clearly what's happened, the history of the examination, the investigation. If you've needed a chaperone, then clearly a chaperone is going to be another person who can say what happened. It's protective for the patient and for you. If you do have a chaperone, just remember that they need to see what you're doing, so they shouldn't be up at the head end, for example, if you're doing an intimate examination. But I think rather than saying you're lying, you can set out what you think happened, you can explain the management and your rationales, and you can say you apologise. You're sorry that there was a misunderstanding and it was never your intention for them to get the impression they did. It can be really hard, especially if you think they're out and out lying, but it is really important to stay professional.
Yeah. Sorry, Ed.
Ed, we can't hear you.
I hear you properly.
I am muted. Well, yeah, thanks, Jerard and Gaynor. I mean, I'd endorse that. I mean, I think there's two different things. Firstly, I agree that we should be slow to infer that someone's lying because their recollection is different to yours. That can work both ways, and that's difficult. On the other hand, whilst you don't want to be inflammatory in a response, if there is objective information you can use to set out a timeline to show that that simply didn't happen, and we sometimes have call recordings, so more commonly in primary care, you shouldn't be inhibited from using that.
Yeah.
And that's why the bit that seems boring at the start of the response, which is your factual account of what happened, is actually really important. It's the way of getting that point across. And I think we have another one here, which I think you did address, which was the question here of why should we apologise if nothing's been done wrong. And I don't think you do need to apologise if nothing has gone wrong. You can take a conciliatory approach. You're not trying to inflame the situation. But if nothing's gone wrong, the important part of the response is explaining against some objective criteria as to what should have happened, did happen. So really then the focus is on explanation as to why that's the case.
And on that point, I think, sorry, Ed, I think on that point, referring to, very often we're following guidance, or at least using guidance in our decision making, and referring to that in the letter and saying this was the guidance we used, this is why we did what we did, and this is national or local guidance that is well established. Sorry, Ed.
But an apology isn't saying that you've done something wrong. An apology can be just an empathetic expression, an acknowledgement that you understand that they're unhappy. So you might say, I'm so sorry to learn that you have had cancer, and it must be difficult to complain at a time like this when you're already facing lots of other challenges. And that's not saying I've done anything wrong or I've delayed my diagnosis. It's saying I'm really sorry that you're in the situation you're in, and that can really set the tone for an empathetic and supportive response, rather than a response where you are saying it wasn't me, Gov. in essence. And one way of doing things is writing in an active voice rather than a passive voice. So I'm very sorry, not it was discussed. You'd say we discussed, and that's again, so that's a much more empathetic tone.
I was just going to say that there was one that I had recently where a radiologist, a lesion on the edge of a scan, that, and of course, unfortunately, some years down the line, the patient developed a malignancy in that area, and the immediate assumption was that the doctor had missed something. Of course, they hadn't missed something. They had noted something was there, but they were doing a scan that was not optimal for that area. It was an edge thing, and it had been discussed, and nobody was critical within the realm meeting. But for the patient, they say, well, I had this really big expensive scan, you injected me with dye, you stuck me on a table, I was there for ages, it took ages to come back. Why on earth didn't you see the cancer that was there? It's going to kill me in the next 6 months. So you can see how it works for them.
There, and sorry, I'm rushing you on because we've got loads of questions coming in now. So and they're all really interesting. So on a slight sort of change of tack, I've got I think something which we've certainly seen examples of here, where the comment here, and I'll read it out directly, is: in my experience, I've some concern that the duty of candour process has made patients lose trust with the organisation, clinicians, rather than seeing the duty of candour process as striving to be open, transparent and keen to learn. I'd be very keen to hear others' perceptions and any tips on how to avoid this. Any thoughts in that area?
I think that the one thing that is always coming up is how doctors and trusts are trying to keep things hidden. So I think duty of candour is extremely important, but calling it duty of candour, what it means, there are two different meanings. There's personal duty, which is when you say, I'm terribly sorry that you've had this complication after the operation, we've discussed it, or I'm very sorry you were late for your operation, we had a difficult schedule that day, compared to the organisational duty of candour, which is a statutory duty of candour, which is something that has to happen. But I think you can sort of prefage it. Apologising isn't supposed to be something which makes the doctor look negligent or incompetent. It's supposed to be something where you explain what's happened, you try and put things right. If you can, you explain what will happen next. And it is the GMC's express guidance that must happen. So if you go to good medical practice at paragraph 45, you'll see that is a specific duty of doctors. So I think if it's done in the right way, as Ed said in the chat, actually it's helpful and supportive rather than a way of making.
I think it can be lost within different layers, can't it? I think that what we see with this fragmentation of medical practice or medical services, that different organisations are involved. You might have an ambulance trust involved, you might have a mental health trust involved, you might have the A&E involved, and they've all got to apply that. And sometimes the actual journey for the patient can be hard to appreciate from what is coming out from the individual organisations, because sometimes they don't mesh in terms of their responses, which are meant to do, of course. They're meant to all act together, but they often don't. And I do recognise that sometimes what a doctor will see and say is that, I think that there were some failings that could have been addressed. And I think sometimes that is lost within the organisation. There's still a fear of admitting that. The problem is that we don't advise organisations, we advise doctors, we advise individuals. So we don't have sight of that, and it would be rare for a medical director to come to us and say, what do you think? Does this engage our duty of candour? But I think we can advise our doctors, but ultimately the organisations have to do it, and I think they're still pretty poor at that.
And I think you've got to also think of what the duty of candour process is. It's staged. So the first is simply to say something has gone wrong, explain what that is, what the effects are, what you can do about it now, and how it will be investigated. And then to follow up once you have investigated. And occasionally, I think we've seen this go wrong when, without investigation, it said that, look, this or that was done wrong, when in fact it wasn't, as things come out, and that can really lead to a breakdown in trust. So that's certainly the case. a quick one here, which said, we're discussing about complaints. Are there specific criteria or set examples which can give us an idea of the types and nature of complaints? Well, I'll say as a starter for that, in secondary care, it's often related to treatment, isn't it? Diagnosis of conditions, etc. In primary care, it's often in relation to delays in referral, etc. Running through all of those, often it's that difficult consultation or communication issues that can sometimes trigger the complaint. Would you say that's broadly true?
Well, we've got stats to back that up. I mean, the NHS England, the other nations in the UK don't produce the same degree of data nowadays, but NHS England does produce the data which says that communication is still right up there, along with clinical treatment as being one of the major causes. And if you add in perceived behaviours of staff, then it tends to even overtake the clinical treatment of patients.
I think communication is the key thing. You know, if you can start off a consultation well, and you can be empathetic. Some people are just better at have better communication skills than others. There are things that you can do. You can certainly go on training courses, etc. But there are some people who are just better at it, and watching them is amazing. But I think it's poor communication, or maybe just a lack of communication in that particular instance. I mean, there's always somebody who will get on better with somebody else, and so if you get into a situation where you think this is not going well, you might want to ask for a second opinion, or for one of your colleagues to come in, or you might want to sort of halt it for a while. You know, all of us have bad days when communications doesn't go well.
Not good. Great, thank you for that. Now, I'm just mindful of time, so there's a couple of things where I'm going to direct the question sort of elsewhere. We've got a really good one here about the duty of candour, saying, does every mistake, however trivial, invoke the duty of candour? The answer is no. There are thresholds to that. In secondary care, it's moderate, more than moderate harm. That's quite a complicated area, but we do have guides on our website, so have a look at those. If you just Google MDU duty of candour.
So if you go to that QR code, that will take you to the learning. That takes the e-learning. There's duty of candour in there.
So we've got that. We've also had questions about differential outcomes based on protected characteristics at the GMC. The GMC have a tool called Data Explorer that has that information. The only observation I'd say for that is, whilst the GMC surely has issues, and we're certainly not here to defend the GMC, there are issues in terms of the roles doctors have, the tendency to refer, etc., and all those things are sort of addressed on that website as well. We've had another question about the basics of the complaints procedure. Again, on our website, there's a complaints guide in relation to that. But can I put to you the second part of that question is, well, what's a doctor's role in the complaints process in a hospital? Is it a department that deals with it? Do they just have to write a statement? Might they be involved in investigating?
Well, it varies, doesn't it? Depending on your grade and stage within the department. You know, a senior consultant may well be charged with some degree of investigation if they've got a managerial role. A more junior person may just be asked to provide a statement. So the short answer is, typically it depends. You're not likely to have to be asked to investigate it if you're a registrar or a non-consultant hospital doctor. It's not going to be a role. A consultant may be asked for an overview of what has occurred, trying to pull together the strands with their knowledge, but the investigation should be done by the PALS team or equivalent, and then at least signed off by the responsible person for the organisation. That's enshrined in the statute.
So we have 5 minutes left, so you can see I'm itching to go on to the another one here. This one is, may I know what are the points we should be careful and particularly concerned when writing a statement for an SAER, so a significant event or an adverse incident review? Gaynor, any thoughts on that?
So a brief background, what went well, what didn't go well, and the learning points. So you might refer to guidance if there's some sort of clinical issue, you know, which has guidance for it, and then any actions, you know, what action should be taken. If you have a significant event review, which is undertaken by the trust, then usually there will be a whole section related to the actions that will be taken, and they may be at sort of the clinical governance level, or they may be at a more personal level for particular grades or doctors. I saw one recently where it said doctors should be reminded of their need to record their notes in detail. So they may be global, they may be more personal to the particular area. The organisation may have a particular team who do the incident investigation itself, rather than a consultant in the department. It's usually somebody who's a bit away from the actual event.
So what I was going to add to that, I think that I agree with all that, was to say that it's all disclosable. So what you put into your significant event is going to be established. It's going to be pretty much the same as goes into the factual account in your complaint, and it's going to be identical, or at least it's going to share the same facts as your what goes into a coroner's report, or a report to a court. So it's important that it all lines up and it's the same. We don't want to be caught out by having slightly different information presented in one than another. And similarly for your reflections, if it mentions anything factual, and that's not really the point of it, there's nothing going to be disclosed in that that's not going to be in the other parts. I don't think being careful, I think Dr. X got this wrong, it was all Dr. X's fault. I think you just state the facts and move on. You concentrate on your part of it. Ed, anything you want to add?
It's not a blaming exercise, it's not. But in a significant event trust report, you will know who you are, because you'll be Dr. A or Dr. B, and you'll know what you've done. So sometimes the reports do say this could have been done in a different way, or this wasn't considered, but there's no actual blame of an individual.
Yeah, I say one thing, so I know you recommend Ed was to say that if you're a junior and you're moving on, make sure your trust or health board know where you're going and you get to see the final report, because what you don't want to do, is I've seen it a few times, is doctors being made aware some years down the line of a problem that was in an RCA or an SEA, and they weren't even told about it.
Sorry, we're really tight on time. I think that's absolutely right. I think the key is make sure you pay attention and do a really accurate report, because things that, as Jerard said, are undone later can cause real issues. We have another quick question here in terms of how does an RO know that complaints have been properly reported to them, involving in the independent sector for doctors they're responsible for. I think in a very quick thing, we just say, look, that has to really you have to have a robust appraisal process where the appraisers, look at that information and seek it and see logs of complaints from organisations where they're working. I appreciate that's more challenging in that. We're right tight on time, so I guess what I'd say is, look, I'm really sorry if we haven't got to your complaint, to your questions. We do have one about patients in particular things, particularly with body dysmorphia, sometimes making sort of malicious complaints, etc. Should the doctors have a right of redress? It's incredibly frustrating, but frankly, as much as we would support that there should be some management of vexatious complainants, I think that probably is not going to happen. So it's not something for that. And we have another one here about whether it's PALS who responds to the complaints if the clinicians are busy. It's not really about who writes the complaints. If there is a clinical complaint that needs proper investigation, it's going to need input from a clinician to be able to deal with it. So I think, oh gosh, well, thank you so much to Gaynor and Jerard, and thank you so much to the audience for such amazing questions, but I'm afraid we're at time, so I'm really sorry if we didn't get to your questions. Some of you have measured about individual issues that you might need support with. If you contact us at advisory@the.mdu to go on our website and submit your questions in the normal way for that, and we can pick those up. So thank you very much.
We've also got the timelines. Sorry, I don't mean to. We've also got the timelines. Somebody's asking for those in all of our guidance documentation, and it'll be there for you.
Excellent. Thank you very much indeed, and good night.
Thank you.
Bye-bye.